This is AHJ today at the annual scientific sessions of the American Heart Association in Dallas 2013, and we're discussing today the CANHEART study with the primary investigator Chuck Tu from Toronto University and with the discussant Leslie Curtis from Duke University. Welcome.
Thank you.
So Dr. Tu, what made you do the CANHEART study? What was the background? What was your question?
Sure. So Canada is one of the world's most ethnically diverse countries. And in spite of that, there's very little information on the incidence of cardiovascular disease among different ethnic groups in Canada, particularly the immigrant population. And so we thought it would potentially be very interesting and important to study the prevalence of traditional cardiac risk factors, as well as the incidence of cardiac events in recent immigrants to Ontario, Canada's largest province.
So what is an immigrant and when are you a citizen in Canada?
So typically what happens in Canada is you apply initially to become a permanent resident, and that's a 3-year time frame. And after you've been in Canada for 3 years, then you can apply for permanent citizenship.
So these are people that are individuals that are not more than 3 years in Canada.
So actually in our study, what we did is we studied all immigrants between 1985 and 1998 who immigrated to Canada. And then we started following them as of the year 2000. And calculate the 10-year incidence of major cardiovascular events between 2000 and 2009. So the duration in Canada was variable. On average, it was about 8 to 9 years.
Oh, I see. I see. And they came from all over the world.
That's right. What's remarkable is the remarkable diversity of immigrants to Ontario. In our study, we had immigrants from 196 countries of birth, covering virtually the entire planet. The largest number of immigrants were from countries such as China, India, and the Philippines, but we literally had people in Ontario really from all over the world.
But you grouped them in several areas. Let us know what you put together.
Sure. So we decided to, in order to make things more manageable, we grouped the immigrants into 8 major ethnic groups. First, there was a white Western European group, which also included the immigrants from Australia and New Zealand. We had a white Eastern European group. We had a group from Latin America.
Eastern European is the former
Soviet bloc. That's right. We also had a group from Latin America. We had a black group, which is a combination of immigrants from sub-Saharan Africa as well as the Caribbean. We had a group from the Middle East, West Asian and Arab immigrants. There's a group from East Asian immigrants from China, South Korea, Japan. A Southeast Asian group from Vietnam and the Philippines, as well as a South Asian group, which are immigrants from India, Pakistan, Sri Lanka.
And what did you assess in these individuals?
So in each of the ethnic groups, we assessed the frequency of a major cardiovascular event. So this is after 10 years, how often were they hospitalized for AMI, CHF, stroke, PCI, CABG surgery, or cardiovascular death, and created a composite outcome measure. We also looked at the prevalence of risk factors such as smoking, diabetes, hypertension, and we measured the total divided by HDL cholesterol ratio, which is our main lipid measure.
And so where did you obtain the data? Is this thanks to the federal system that you have, health system in Canada, where everybody is sort of in a database?
Sure. So we have a single-payer system in Canada, and we have a large number of population-based health databases which cover everyone. We got the immigration data from the Canadian government, which has the immigration statistics, and we linked it to 8 other population-based health databases. So we have population-based survey databases, which gave us the smoking data, and we have physician claims data, which we use to identify diabetics and hypertension. Once the physician diagnoses someone has one of those conditions, they show up in that database. We have these large laboratory databases with all the lab tests for the outpatients in the province, and we have hospitalization as well as vital statistics data.
And what did you find?
There are a number of important findings. I think the first overall finding was that overall there was about a 40% lower incidence of major cardiovascular events in the immigrant cohort as compared to the long-term residents. So we also had a control group of people who already been in Ontario for a long time. But we also found really striking variations in the incidence of events among immigrants from different parts of the world. Overall, there was a 4-fold difference in the frequency of events. The lowest incidence was found in East Asian immigrants from countries such as China, Hong Kong, and Taiwan. And the second lowest risk was found in white Western European immigrants from the US and the UK. The highest incidence of events were found in the South Asian immigrants, India, Pakistan. The second highest was in white Eastern European immigrants, countries such as Russia, Poland, and the third highest incidence was the immigrants from the Middle East, Iran, Iraq, those countries.
And if you talk about incidence, that's primarily, of course, the SMI, stroke, as you mentioned.
Yeah.
What about the risk factors? Were they aligned with the events, or was there any diversity there as well?
So the pattern of risk factors varied across the different ethnic groups. And we looked at the traditional risk factors, and we found that it was the total divided by HDL cholesterol ratio, which appeared to have the strongest correlation with the incidence of events. So
through all the groups?
Yeah, throughout all the groups. That appeared to be the most important of the traditional risk factors.
But was there also a difference in risk profile? For instance, hypertension is very prevalent in China and in Japan. Yeah. Did you notice this or not?
We actually noticed, at least in the immigrants to Canada, that the incidence of hypertension was actually relatively low in the Chinese immigrants. We did find a pretty high incidence in the immigrants from Africa, and also the Southeast Asian immigrants from the Philippines. They had a very high prevalence of hypertension. And for diabetes, we also found the immigrants from Africa and the Caribbean, as well as the South Asian immigrants, had the highest prevalence of diabetes in terms of the groups that we looked at.
Yes, that's very interesting. Now, did you expect that actually the Canadians do worse than the immigrants? And if so, how do you explain this?
Yeah, so that was one of the surprising findings from our study. And so although we found large variation across the ethnic groups, actually the highest risk group actually was the long-term residents of Ontario. And it's still a bit of an unexplained thing, because the risk factor profiles, they smoke a little bit more than average, but it wasn't strikingly out of keeping. We think one factor that may explain this is what we call the healthy immigrant effect, in that immigrants who choose to migrate probably self-select in terms of being healthier than the average population in their native country.
Stays there.
Yeah, and you know, they typically are younger and motivated, and so I think that's part of the issue. In Canada, also, before you immigrate, each immigrant is required to pass a physical exam, and if they do detect serious chronic medical conditions that may impart significant costs on the healthcare system, they can be excluded on that basis alone. So that may play a role as well.
There's another bias in there as well. Yes, yes. So, our discussant, what do you think about this study?
I think it's a fascinating study. I guess I was struck by a couple of things. The first was that really fairly wide variation in baseline risk factors and also in some sociodemographic kinds of factors. In particular, language proficiency, which varied quite a bit across the groups. And to my eye, suggested that really any sort of prevention programs would have to be tailored to those different ethnic groups, or at least we'd have to understand how best to tailor those in order to expect them to be successful. I think I was also struck by, again, that not quite lining up of the risk factors with observed incidents, and wondered, to what extent do you think that acculturation into the Canadian society plays a role there, or what do we know about the interplay of acculturation with risk factors, for example?
Sure. We have studied the issue of acculturation a bit in the context of other studies, and we find that in general, the longer immigrants are in Canada, the worse the risk factor profile is. And so I think that will play a role, and it'll be interesting to see whether the incidence rates, say, converge over time as people become more acculturated. It's also interesting that definitely the risk factors alone do not explain all the variation, and it gets me thinking and wondering, you know, about you know, the pre-migration exposures in different parts of the world. And, you know, the world's very different places. And I think, you know, a lot of the people who are immigrants form their lifestyle habits at a relatively young age before they've come to Canada. And so they're already smokers or non-smokers. They've already decided their dietary practices. Their weight's probably established by the time they come and we start studying them. And so, you know, I think there's such different circumstances around the world that maybe an independent risk factor that we don't quite have a handle on that maybe contribute to some of the variations we saw.
Mm-hmm. Mm-hmm.
What about education? You mentioned language proficiency. Could you quantify this a bit more? Because some risk factors are related to the educational level of individuals.
So about 20% of our cohort had completed university prior to coming into the country. We haven't had a time yet to really study the relationship between education and the risk factor and incidence in different ethnic groups yet. One would expect that in general, I guess the higher the education, the lower the incidence, but we haven't had time to study that issue, but we have that data.
But what's really, I'd like to come back to the Canadian paradox. So the acculturation coming to Canada, what happens that they increase their risk? Is this diet, lifestyle, or is it climate? What is it?
We don't really know for sure. One hypothesis that we do have is, our sense is that the Western European immigrants, for example, they have half the incidence of the immigrants to Ontario, and yet, presumably their genetic background is similar. Part of it may relate to a more sedentary lifestyle in Canada. So as opposed to Europe, in Canada, the public transportation systems aren't as good. There's a lot of people have to live a very sedentary lifestyle in terms of driving long distance to get to work, and that may be part of it. There's also the bad weather in the winter time, which probably also decreases physical activity. And we do know from other studies that we've done, the incidence of heart attacks and strokes rises in the winter in Canada as compared to the summer.
We see that also in Switzerland, yes. Yeah.
So that may be part of it. Diet, in North America, I think our diets are not the healthiest, and our restaurants probably be worse than some of the European restaurants, in the sense that the portion sizes can be quite large. We don't really regulate things like salt intake in food, and that may play a role as well.
Well, thank you very much indeed. That was very enlightening, and I think we're looking forward to further analyses of your interesting study.
Thank you very much.